In a patient with a resectable pancreatic cancer, upfront resection is feasible. But is that the correct option? Is that the only option? Till date, we do not have answer to the question that in a patient with resectable head pancreas cancer, whether to operate first and give adjuvant chemotherapy or to give neoadjuvant chemotherapy. There is no level 1 evidence to support either of these two. The thought process for considering neoadjuvant chemo in a resectable patient, as many cancers, just like many cancers, assessing the biology of the tumor. Though the CT appears resectable, though the patient is fit for surgery conditionally, and though the CA19-9 may not be elevated significantly, there may be circulating tumor cells in the body, and there may be CT occult micrometastasis in the body. And after the surgery, these micrometastases may flare up, and the patient may succumb to metastatic disease very soon because of the inherently aggressive biology of that particular patient's tumor. By giving neoadjuvant chemotherapy to these patients, we can assess the biology of the tumor. And if a patient's tumor progresses while on neoadjuvant chemotherapy, we know that the inherent biology is very bad and the patient would have fared worse even after a curative resection. This is one advantage of giving neoadjuvant chemotherapy to patients with resectable pancreatic cancers. And the more important reason is because of the major complications that happen in a lot of patients with who undergo Whipples and a prolonged recovery that follows. Up to 50% of patients who undergo curative resections may not receive adjuvant chemotherapy. The 1 year cancer specific mortality after a Whipple's resection, upfront Whipple's resection, is 30%. So, if 100 patients were to undergo upfront Whipple's for Ca Head of Pancreas today, 1 year from now, 70% of them are alive, 70 of them are alive, and 30 of them are not alive because probably of distant failure. So, these 30 patients had actually undergone a very futile exercise of a supramajor surgery followed by a prolonged recovery. The thought process against neoadjuvant chemotherapy. Chemotherapy cannot be given without a tissue diagnosis, so we need an ERCP with a biopsy. SOS stenting. Most patients will require stenting because of the obstructive jaundice, and for receiving neoadjuvant chemotherapy, they must have a bilirubin less than 3. So these ERCP stent related complications, pancreatitis, hemorrhagic or necrotizing pancreatitis, causing further complications of pancreatitis like SMV portal vein thrombosis, making these patients technically unresectable. So the patients were technically resectable at baseline. We wanted to give neoadjuvant chemotherapy, so we sent for ERCP stenting. And because of the complications, 10% may become technically unresectable. So this is one disadvantage of giving neoadjuvant chemotherapy. The other hypothesis is that when neoadjuvant chemotherapy is given in the presence of a high tumor burden, there is a higher chance of the tumor cells developing resistance to the chemotherapy rather than dying out of it. So, this is one thought process that is held against neoadjuvant chemotherapy. So, now we have discussed the philosophy behind it. What is the evidence? Christians and allies in a single institution evaluated 69 patients with resectable head pancreas cancers and they gave neoadjuvant chemotherapy to all 69 of them. Only 60 could undergo surgery after neoadjuvant chemotherapy. 8 patients developed metastatic, that is, they failed biologically. One patient developed a poor performance status on neoadjuvant chemotherapy, that is, he failed conditionally. So, there are two very different angles to look at this particular point. Number one, we had a patient with a resectable head pancreas mass and we lost a window of opportunity to treat the patient, to resect the patient. We sent the patient for NACT, and the patient eventually progressed and developed metastasis. So, are we wrong in doing that? This is one angle of looking at it. We might not know if this patient had undergone upfront surgery, would he have developed metastasis? The other angle of looking at it is while on systemic therapy, if a patient were to develop distant metastasis, that means the inherent biology of the tumor is very bad. So, if we had subjected the patient to an upfront surgery, he would have anyways develop distant metastasis and succumb to the disease. Plus, he would have also had to undergo the trauma of the supramajor surgery and the prolonged recovery that followed. So, this is anyone's guess, but the ultimate conclusion of this trial was of the 60 patients who eventually underwent surgery after the neoadjuvant chemotherapy, they had a very good survival of 45 months. The median overall survival of 45 months. It's close to 4 years. Bogdad, the analysis, did an observational retrospective study of about 15,000 patients with resectable and resectable pancreatic cancers, and they found that patients who received neoadjuvant chemotherapy had a better overall survival of about 26 months compared to 21 months for patients who underwent upfront surgery. But again, this was observational and retrospective. Priopanc was a neoadjuvant CTRT trial, multi-center phase 3 randomized control trial by the Dutch Pancreatic Cancer Group, where 248 patients were randomized into two arms. Though they did not use the recent consensus criteria for resectability, ISGPS criteria, and they did not use the multi-agent modern systemic therapy that we use in practice now. They randomized the patients into two arms, one arm receiving gemcitabine RT surgery followed by maintenance gem 4 cycles, or upfront surgery followed by 6 cycles of gemcitabine. The conclusion was, the findings were, the pathological endpoints: R0 resection, pathological node negative, that is the final HPR being node negative, perineural invasion. All these were much better in the arm who underwent neoadjuvant therapy, whereas the survival endpoints were not very different between the two arms. But on a subset analysis, patients with borderline resectable pancreatic cancers, not the resectable ones, had a significant survival advantage, whereas the resectable pancreatic cancers did not have any significant survival advantage with a neoadjuvant regimen. There are some ongoing trials which are expected to shed some light, better light in this topic. Adjuvant therapy. Any patient who undergoes surgery for a pancreatic ductal adenocarcinoma should receive systemic therapy. There is absolutely no doubt about it, irrespective of the stage. So, after a Whipple's resection, whether to give chemo or chemoradiation. In a very old trial conducted several decades back, patients were randomized to observation versus chemoradiation, and chemoradiation offered a survival advantage. But the caveat was, in the arm which received chemoradiation, patients also received maintenance chemo for 2 years. So they were not sure whether the survival benefit was because of the maintenance chemo or the chemoradiation per se. So this was evaluated further in the URCT 40891 trial, where the chemoradiation arm did not receive any maintenance chemo and did not have any survival advantage. Further evaluated in the SPAC1, any arm which received adjuvant radiation fared worse, any arm which received adjuvant chemo fared better. So, this trial was criticized for multiple reasons because of the complex multifactorial design and all that, but this established chemotherapy alone without chemoradiation as an acceptable adjuvant treatment approach. While evaluating adjuvant chemotherapy, there were several trials which proved beyond doubt. CONCO 001, SPAC3, all these trials proved beyond doubt that adjuvant chemo offers a survival advantage over and above observation. In the further trials, the SPAC4 and APACT, combination chemotherapy with GEM plus CAPE or GEM plus nab-pacli fared better than gemcitabine alone. And in the most important of the trials, PRODIGE 24, multi-agent systemic chemotherapy, modified FOLFIRINOX, had an extremely significant survival benefit over and above gemcitabine alone. So patients had a median OS of 54 months, that is beyond 4 years. So this was a phase 3 randomized control trial where patients were randomized after surgery to modified FOLFIRINOX or gemcitabine, but this randomization was allowed only if the patients had a complete recovery from Whipple's with an excellent performance status and a low CA 99. So these are biologically and conditionally the best of the best patients, but still, achieving a median overall survival of 54.4 months was a terrific success. So this is the standard of care right now after a resected PDAC. Two important points to note from Prodigy 24. At 60 years, that is 5 years after the surgery, the survival advantage of FOLFIRINOX persisted, showing that even after an upfront resection, there are micrometastatic disease cancer cells in the body on which the chemotherapy acted and provided a long lasting survival benefit. Number two, just the opposite. Just 6 months after the surgery, the curves start falling apart, meaning there are some patients whose inherent biology was bad and they might have harbored micrometastatic disease at the time of surgery. So, after the surgery, because of their micrometastasis, they immediately started developing systemic disease and started succumbing to the disease. So, the curves started falling apart very quickly. So, this is one argument that can support the use of neoadjuvant chemotherapy in patients with resectable pancreatic cancer. To sum up, in a patient with a resectable pancreatic cancer who's sitting in front of us, he's fit for surgery conditionally and biologically he's not borderline resectable. His CA 99 is not very significantly elevated. Anatomically, he is resectable. He has a resectable head pancreas mass. Whether to subject the patient to an upfront surgery or to neoadjuvant chemotherapy is a philosophical decision taken by the individual multidisciplinary team treating the patient. There is no level 1 evidence to support the superiority of one approach over the other. This is reflected in the NCCN guidelines as we discussed earlier. Both are accepted standards of care. And one more important point to remember, patients who undergo an upfront surgery have a very good survival advantage only if they complete all the adjuvant chemotherapy. If they are not able to tolerate the adjuvant chemotherapy because of complications following a Whipple's procedure, then the whole surgery might have just become a futile exercise. This being said about resectable pancreatic cancers, borderline resectable pancreatic cancers, there were a few trials evaluating neoadjuvant treatments, neoadjuvant chemo or chemoradiation. Zhang and Alice, in a multi-center phase 3 randomized control trial, evaluated upfront surgery followed by CTRT and maintenance chemo in patients with borderline resectable pancreatic cancers. And the trial had to be stopped because the interim analysis showed excessive deaths in the upfront surgery arm. In another single institution trial, the Massachusetts General Hospital evaluated patients with borderline resectable pancreatic cancers with 4 cycles of FOLFIRINOX multi-agent systemic chemo. When the patients did not have progression, they gave further 4 cycles FOLFIRINOX. Again, ruling out progression, an MDT was held. If the vascular involvement which was there at baseline persisted, patients would undergo long course RT with CAPE. If it had responded well, the patients would receive short course RT with CAPE. With this extreme biological and conditional selection, because the patients were able to tolerate the multi-agent systemic chemotherapy, such intensive chemotherapy, so they are conditionally very fit and they have not progressed during such a long course of chemotherapy, so they are biologically fit. So by this, they could achieve a median overall survival of more than 3 years for patients with borderline resectable pancreatic cancers. So, for borderline resectable pancreatic cancers, though there is no level 1 evidence to support neoadjuvant treatment, the world is united. The global consensus is that no patient with a borderline resectable pancreatic cancer should undergo an upfront resection. All patients should be subjected to some form of neoadjuvant therapy. The new decision between neoadjuvant chemotherapy or chemoradiation is left to the multidisciplinary team treating that particular patient. Whereas in locally advanced pancreatic cancers, our aim is to convert them to at least borderline resectable pancreatic cancers so that we can do an attempt at the resection. Of course, these resections are quite complex, involving vascular resections and reconstructions, and are to be attempted only at very high volume centers which perform these complicated surgeries at a high volume. Now, neoadjuvant systemic therapy is, of course, without any doubt. The role of radiation in locally advanced pancreatic cancer was evaluated in three trials: GERCOR, the most important of which are GERCOR, SCALLOP, and LAB07. All three of them have a very similar trial design. So, start with systemic. If there's no progression, they were randomized to chemo or chemoradiation. And in all the three trials, chemoradiation fared better than chemotherapy alone. So, the basic funda of treating locally advanced pancreatic cancers is that there should be an MDT meeting, and the roadmap should be laid on right at the outset. And patients should be started on systemic therapy without any doubts. If they withstand this biological and conditional test of systemic therapy well, and they do not progress, then they are offered local regional therapy in the form of chemoradiation, again as a neoadjuvant intent. And if they still can withstand all that, if they get downstage to a borderline resectable pancreatic cancer, surgical resection with vascular resection and reconstruction can be attempted. Thus concludes the management of pancreatic cancers.